On March 4th, 2016, the FDA approved the use of ibrutinib as first-line therapy in patients with chronic lymphocytic leukemia. And this has raised the question among many patients, what is the role, if any, of conventional chemotherapy in the management of the disease? Well, first we have to look at the question of what was actually studied in the patients who were on the RESONATE-2 trial, which compared chlorambucil, a treatment that is largely not used by itself anymore in the United States, and compared it to ibrutinib. It is clear that the patients treated with ibrutinib had a very significantly improved progression-free survival, that is, time until the disease started to progress, and they had a better overall survival, but that was in part an artifact of the very poor activity associated with chlorambucil, which is why we don't routinely use this in clinical practice. This trial is a good example of one that was done to clearly identify the role of ibrutinib for regulatory purposes, but was actually less useful for us to help drive clinical decisions. I believe that the older patient, the frail patient, the patient with deletion chromosome 17p, these patients probably will benefit from treatment with single-agent ibrutinib as upfront treatment. However, this is chronic therapy. Patients are on therapy for a long period of time, and there is the risk of toxicity developing during the course of treatment. Furthermore, the RESONATE-2 trial has very limited follow-up so far. So for the patient in whom chemotherapy is appropriate today, in 2016, because it remains time limited and we don't know that there's a clear survival advantage of starting with ibrutinib, I feel that starting with chemoimmunotherapy is still a very reasonable choice. And these are discussions that have to be had between the patient and their treating doctor.